a fellow in the emergency department here at Mount Sinai. She is additionally an assistant professor of emergency medicine and a clinical instructor here at the Mount Sinai Hospital, and she works both clinically as well as a researcher and a mentor to the residents. Dr. Love did her med school at University of Pennsylvania, as well as her residency in emergency medicine at University of Pennsylvania, and then did a fellowship in medical toxicology at Oregon Health and Science University in Portland, Oregon. And now she came to join us at Mount Sinai in 2021. Dr. Love today is going to talk to us today about new ideas in medical toxicology, and it's my pleasure. Thank you so much, Dr. Love.
Of course, thank you so much for having me. I'm really excited to be here with you guys today. And thank you for that very gracious introduction, Evan. The title of my presentation is called, I like to call it Tox Trending. It's sort of what I consider new ideas in medical toxicology. A lot of people think of toxicology as kind of a little bit of an old field that isn't making a lot of new strides in terms of treatment, but there are some new things that are coming down the pipeline, and I'm really excited to share them with you today. The other thing I will say just about my lecture is that my lecture is interactive. So if you have your phones or a split screen on your computer, we are going to be using Poll Everywhere for this to work through some cases and sort of do some polling of the audience with some questions that are relevant to the presentation today. So just financial disclosures, I don't have any. This is a little bit more accurate about my life right now. And so with the title Tox Trending, you might be thinking, oh, she's going to talk about some of these like social media fads that are happening, people who do these different tox challenges like the nutmeg challenge or the cinnamon challenge. The one that comes up every year or every few years, the diphenhydramine challenge. I'm not sure why the most recent version of it elected to have people cook their chicken in diphenhydramine, but they do invent new ways to pose this diphenhydramine challenge on social media. And I have taken care of particularly teenagers who have gotten pretty sick from the diphenhydramine challenge. So it is a real thing, but that's not what I'm going to talk about today. Sort of the three big topics that I'm going to talk about are will it dialyze and the use of dialysis in the poisoned patient. Acetaminophen is not just NAC anymore, and then veterinary tranquilizers among us. And so I'm really excited to talk about these things with you. So like I said, my lecture is interactive. And so if you have your phone or your computer available, this is the Poll Everywhere site that we will be using throughout the lecture to work through some cases and some multiple choice questions. And I'll just give you a little bit of time to log into that. Don't be shy. This really working through the Poll Everywhere will make it a more fun and interactive lecture. So for any of these cases or questions, if you don't know the answer, just guess. It's more fun that way. All right, so we'll move on to our first case. And again, that Poll Everywhere site URL, if you missed it, it'll be up on the next screen, so don't worry about it. Case number one is a 28-year-old female presents to the emergency department following an ingestion of an entire bottle of one of her antidepressant medications. She is lethargic and slow to answer your questions, and her partner reports that she had some vomiting at home. You can see her vital signs there below, and give a thought about what she ingested based on the case. So I always like to sort of see the changes in the poll and the dynamic answers that come back. And I usually try and give people enough time to see when the poll kind of stops moving to move on and reveal my answer. Seems like we're in a pretty good place right now. And so if you picked lithium, you are correct. And this graphic is sort of a metaphor for lithium. If you ever have seen the movie Zootopia, the sloth that works in Zootopia moves very slowly. And in cases of lithium toxicity, patients tend to have significant cognitive slowing, and their movements will be very slow. Their answers will be very slow. You'll fire off like 3 questions to them, and after your 3rd question, they'll answer your 1st question. And that is sort of what I think of as the Zootopia sloth when I'm thinking about a patient with lithium toxicity. And the CNS depression that results from this sort of becomes relevant moving into the 2nd part of the case. So continuing, you start the patient on some IV fluids, and she becomes increasingly somnolent and unresponsive to noxious stimuli. Her creatinine is 2 and was previously normal. You try calling the poison center, but the phones are broken. So what would you like to do next? This one is so much easier than the previous one. I'm surprised no one's answered.
Jen, I answered. I'm not sure why it's not coming up.
Oh. Give me 1 second, guys. Let me see. There we go. Okay. All right. That's the reason it was on my end. Okay. So yes, if you answered B and C, call nephrology and call a tox consult, you are correct. So when I'm thinking about methods of enhanced elimination in toxicology, I sort of break it into these 2 brackets. One is intracorporeal treatment for patients, and those are things that we use to sort of manipulate the elimination that's completed by the individual patient. So that's things like chelation, multi-dose activated charcoal, which was one of my favorite things, manipulating urine pH and something like a salicylate overdose. These are all ways that we can kind of modify the way that the body's own elimination processes remove the toxic substance. In contrast to that, you have these extracorporeal treatments, which are things that we do sort of outside of the body to modify elimination. They're essentially additional devices that can do a better job than our own physiologic elimination processes. That includes things like hemodialysis, but also other things like plasmapheresis, liver support devices. There's this really cool thing called Mars, which has been used in tox patients in Canada, not really in the United States. It's like a liver dialysis. It uses an albumin-enriched dialysate to remove albumin-bound toxins. And so those are things we can do sort of outside of our own physiologic elimination. So what might be some of the reasons that we consider something like an extracorporeal treatment like hemodialysis in a poisoned patient? First is supportive care isn't working. So the #1 recommendation of toxicologists everywhere is supportive care. But if you're optimizing supportive care for the patient and it doesn't seem to be working, you might consider an adjunct like hemodialysis. #2 is that the normal elimination route is impaired, either due to a pre-existing condition that the patient has or due to the severity of the overdose and the patient's renal or hepatic functions have been compromised in some way. #3 is that the patients may not appear acutely ill, but their labs suggest severe disease. So in something like a salicylate overdose, if you get a serum concentration back that's very high, something like 80 or 100, the patient might not look terrible at the moment, but that serum concentration indicates the potential for very severe disease, and you might move to something like dialysis very rapidly. So in the very young, there's a lot to gain in terms of removing a toxin quickly. And in the very old, you may need to use these adjuncts due again to their underlying medical conditions. And then finally, can I get an extra benefit for this, invasive, risky intervention that I'm going to use for this patient? And is there a concomitant electrolyte or metabolic disturbance that I could correct? Something like a severe metabolic acidosis that can be fixed while also removing the toxin. So in the spirit of the Tonight Show with David Letterman and one of his more famous sketches, we often get the question in critical tox cases, will dialysis remove this toxin? And there's a great essay on a tox education website called Toxin the Hound. It's by Dr. Diane Colello, who's from the New Jersey Poison Center. And she reviews some of the factors that we consider when we think about whether or not a xenobiotic involved in the poisoning is a good dialysis candidate. So the first is size. And the sort of target molecular size that you're looking for is something less than 15,000 Daltons. Is this something that you need to commit to memory? Absolutely not. As a toxicologist, I don't commit this to memory at all. I look it up and you can typically find it in Micromedics or some other sort of pharmacology reference. But size is important here. The volume of distribution. So volume of distribution is sort of this theoretical volume that we all have in our bodies. It's certainly not a true volume. Otherwise, we would not be able to be the humans that we are. But I think about it in the concept of where does the drug like to go in the body? Does it stay mostly in the blood compartment and is it mostly water soluble? Or is it a drug that's more fat soluble and it'll distribute throughout the body into all compartments? That becomes important as well. Number 3 is the kinetics of the drug. So this relates to, is the absorption of the drug changed by this overdose? Did the patient, for example, take something like diphenhydramine or an antihistamine that then slows their gut motility and could delay the absorption over a longer period of time and not the sort of normal kinetics that we know about and have been studied? Or does the drug form something like a Bezoar, which is a big concretion when multiple pills sort of stick together and they sit in the gut? And that, again, would have this sort of slow, persistent absorption over time. Pieces of that can break off and sort of cause these peaks that happen with absorption. So I also want to be thinking about the kinetics of the drug and how it was taken in the overdose setting. The next one is efficacy. So again, sort of going back to the previous slide, but can this device do better than the body itself? And then finally, the last one is clinical improvement. What do I need to do to treat this person? What's my end goal? Do I need to remove the toxin as fast as possible because the patient's crashing, and removing the toxin and sort of eliminating the toxicity will help with a lot of other physiologic parameters like their blood pressure, their heart rate, their cognitive status? Or is the patient sick but stable and maybe we've passed the time window for something like dialysis and it's just not a really appropriate adjunct right now? So again, these are sort of the 5 things that I'm thinking about in terms of the actual xenobiotic that's been ingested and whether or not is a good option for dialysis. So sort of if you were to put together the resume of a highly dialyzable substance, these are the 4 components or 5 components that we sort of think about. 1, a small volume of distribution. It stays in the blood compartment. 2, it doesn't have a good endogenous clearance mechanism. And so we need this extracorporeal treatment to sort of enhance the clearance. 3 and 4, it's small and uncharged. And then the last one is that it has pretty low protein binding, although that can change in overdose because if you saturate all of your protein binding sites, then you sort of have extra free drug floating around. And so protein binding can become irrelevant there. So we sort of have to think about it in the context of the drug. So how do I find out all this information and find out whether or not whether dialysis is a good option? It's certainly not all in my brain, but I use something called XTRIP. So XTRIP is an international working group that's comprised of toxicologists and nephrologists. And they were created to systematically review the evidence on dialysis of certain toxins and provide recommendations for clinicians to help guide them in the use of dialysis for poison patients. You can Google XTRIP if you're looking for it, or go to their website, which is xtrip-workgroup.org. And they have a really robust website. And the part that I use the most is that tab called recommendations, where they have the recommendations for 22 xenobiotics or categories of xenobiotics, including acetaminophen, beta blockers, toxic alcohols, lithium, mushrooms, like there's so many things there. So it's a really great resource to use. And it's one that's actually pretty familiar to the nephrology community. So if you're calling your nephrologist to get them involved in, potentially starting a poison patient on dialysis, and you cite something like X-Trip, they're pretty familiar with it. What about CRRT? If the patient is unstable, unfortunately, CRRT is not quite as useful in a severely poisoned patient because you're not able to remove as much of the drug quickly and prevent distribution into deeper tissues where you can have that increased toxicity. So for example, in our lithium patient, the toxicity comes a lot from the distribution of lithium into the brain, and CRRT is not going to be able to remove those large amounts to rapidly prevent that distribution into the brain. So it really gets back to the question of clinical improvement. And, are you going to actually gain more from stabilizing the patient, optimizing their, breathing status, their blood pressure with pressors or fluids or whatever else, to be able to get them onto intermittent hemodialysis and then remove a large amount of the toxin? It's generally more recommended that IHD is preferred for poison patients, and X-Trip hasn't actually recommended any of the continuous methods over hemodialysis for any of the drugs that are listed on their site. So what does X-Trip say about lithium? It would certainly be indicated in the patient in our case due to the fact that her kidney function is impaired and her lithium concentration is elevated, not her lithium concentration, her kidney function is impaired, but also that she has this decreased level of consciousness that's worsening. And so certainly she would be a good candidate for something like hemodialysis. So just to summarize what we've gone over so far, when you're considering dialysis in a poisoned patient, consider 1, the clinical goals that you're trying to achieve, and then 2, the properties of the xenobiotic that are sort of at play. And then something like X-Trip is a really great resource, like I said, and you can cite it to your colleagues and use it to help bolster recommendations as to whether or not a patient should get dialysis. All right, so next case, we're going to pivot to a different drug. I'm going to just make sure that it's active, guys. This is one of my favorite tox cartoons, although it's not directly relevant to the next case. It is a favorite of mine. All right. So case number 2, a 22-year-old male arrives in the emergency department following the ingestion of an entire bottle of Tylenol, 500 milligram tabs that he purchased at Costco. So estimated ingestion amount is 50 grams. The estimated time of ingestion is about 8 hours prior to arrival. Patient is obtunded with vomit all over his clothes. And after stabilizing him in the recess area and sending him up to the ICU, his labs come back with an AST in the 1200s, an ALT in the 800s, and an acetaminophen concentration of 256. What would you like to do? This one's a little bit of a freebie. All right, since I don't see too much dynamic change, certainly if you picked any one of those individual A, B, or C answers, it would be a good first start, but all of the above is definitely the right answer in this case. So this is metabolic pathway for acetaminophen, and I love it. And I hope you get as excited about it as I do. But so under usual dosing and usual circumstances for acetaminophen, as you can see, most of it is metabolized through either the glucuronidation pathway here or the sulfation pathway here. And only about 5%, when you take a normal dose, goes through the CYP2E1 pathway, which is important because CYP2E1 is what produces NAPQ, and NAPQ is what causes liver toxicity in acetaminophen overdose. The problem is when you have an overdose, your regular metabolic pathways here and here get saturated and everything spills over into CYP2E1. How do we manage this? Well, NAC is sort of our hero in the treatment of acetaminophen toxicity because number 1, it's a cysteine precursor, and so it increases the amount of metabolism that can go through this sulfation pathway. And then it's also a glutathione and a precursor and substitute. And so it restores the glutathione pathway and allows you to make these other less toxic conjugates with NAPQ and sort of preventing NAPQ buildup and that liver toxicity that results. a lot of us, at least in emergency medicine, and I'm sure also in the ICU, are familiar with this nomogram. It's sort of famous for us in the tox world, the Rumack-Matthew nomogram. Legend has it was written on the back of a napkin over lunch. And we use this nomogram to determine, based on the time since ingestion and the acetaminophen concentration, whether or not to give NAC. And typically, although this is evolving at institutions across the United States and at Mount Sinai Hospital, typically we follow a 3-bag regimen. There's a loading dose that you give in bag 1, an intermediate dose that's given over 4 hours in bag 2, and then the 3rd bag is run over 16 hours. And all of this makes sense for the standard Tylenol overdose, right? Which was created, conceptualized years ago, but it didn't happen in the advent of these Costco-sized bottles of Tylenol, or even like larger sized bottles of Tylenol that you can get pretty easily in the pharmacy. And so in massive overdoses, where you're flooding the system with a lot more substrate that's coming into that metabolic pathway, do we need to think about matching the volume of substrate with a different volume of NAC? Or is the regular amount of NAC sufficient when you're having that much Tylenol coming into the metabolic pathway? So this is a different conceptual nomogram that suggests that when you have a massive acetaminophen ingestion, you actually treat with a higher concentration of NAC, and you try to match the amount of acetaminophen coming into the pathway with an equivalent amount of NAC to help support and restore those other metabolic pathways. And so while our 150 line is sort of the standard line that we use right now, you can see that if you had a 4-hour concentration of 300, you might, or higher as you go up, you're giving higher and higher concentrations of NAC in those bags. So when we look at sort of our standard NAC dosing, like I said before, with our 3-bag regimen, what we will do sometimes is take this 3-hour bag and adjust the dosing of it based on the acetaminophen concentration that we get. From that paper, sort of what has been conceptualized is that you double the concentration of that 3rd bag, or triple it or quadruple it, again, based on the acetaminophen concentration that you have at that time period. And so you're giving a much higher max concentration of NAC for these larger ingestions. So in theory and in concept, maybe this all sounds great to you, or you're at least sort of following along with the idea of it, but how do you actually do this? Well, there's 2 options. One is to work with your pharmacist to create a more concentrated infusion in the same volume, or 2 is to increase the infusion rate and give the same concentration in half the time. But for me, because I was working in a place where we had a 3-bag regimen, I preferred to concentrate the bag and give smaller volumes. Patients, they tend to be in the ICU. They're getting a lot of volume resuscitation in these cases. They develop cerebral edema and renal failure. And so I like to try and minimize the amount of additional volume that I'm giving them in conjunction with all the other volume and treatment that they're getting. And so I like to concentrate the bag, but it's not incorrect to pick option 2 and just increase the infusion rate. It may also be easier to do as we transition to something called the SNAP protocol for the treatment of acetaminophen toxicity. So the SNAP protocol was devised and tested to see if you could actually minimize the secondary effects that you get when you give large boluses of NAC. Primarily, that's the anaphylactoid reaction that develops with that initial 150 mg per kg that's given over an hour. Usually what happens is patients will develop that anaphylactoid reaction and it's mistaken for anaphylaxis, and providers will sort of stop the bag, which is certainly not what you want to do, stopping the treatment and the administration of NAC in these cases. But the SNAP protocol sort of has this other advantage that if you are wanting to give more concentrated NAC, this bag 2 is already at a higher concentration of 200 mg per kg and it's given over 10 hours. So all you would have to do is order a second bag of that, or extend the time over which you're giving that higher concentrated bag. And you can also manipulate the time that it's run over if you're having to give 300 or 400 mg per kg over a 16-hour period. So sorry, I'm just going to again go back and make sure that these are active. But the next case, so continuing on, an NYU Tox fellow answers your desperate phone call and suggests that you give famotidine to the patient. You wonder if he has telepathic powers to know that the patient also ingested a toxic alcohol. And he says, no, we sometimes use famotidine for massive acetaminophen ingestions. What do you want to do? All right, so it seems like everybody's said that they want to ask for the dose of mepazole. Some people keep wanting calling Tox to verify the mystery advice. That's not a bad option either. All right, so why fameprazole? So again, if we look at our metabolic pathway, and we know that when you have these massive ingestions, you have a lot more of the acetaminophen being metabolized by CYP2E1. So fameprazole is a blocks alcohol dehydrogenase, and that's why we use it for cases of toxic alcohols to prevent the downstream metabolism of things like methanol and ethylene glycol. But interestingly, it also blocks CYP2E1. And so there is this idea and thought that if you use fameprazole as an adjunct and use it to block the CYP2E1 metabolism, you actually may decrease the amount of NACI that is produced, in addition to doing all of your other standard things like giving NAC and stabilizing the patient and what we otherwise do. But fameprazole is being considered now in certain cases as an adjunctive treatment. If you think this is crazy, you didn't believe me, there have been a few articles published within the last year about this. So this was a case series of 14 patients that described in detail these individual cases of patients where fameprazole was used as an adjunct. They followed the standard dosing that we use for toxic alcohols, which is 15 mg per kg, and generally gave just one dose. And what they did find sort of across all of the cases is that giving a dose of fameprazole had no negative effects on the patients, and it wasn't unsafe to use. Another review of cases from the toxic database, which is a national database of poisoned patients in the United States, again, looked at this as an adjunctive therapy over 6 years of cases. And what they found was that there's not a lot of standardization to this yet. People are sort of doing it based on some certain criteria. A lot of the cases are patients who, again, are very sick, have very high AST, have a very severe metabolic acidosis. A good number of them are ventilated. Again, a good number of them are on pressors, and about 25% actually ended up dying. So they are patients who are pretty severely ill from their acetaminophen ingestion. And then they surveyed the sites and the people who used fameprazole in these cases. Again, it's not really protocolized right now, so it's sort of being done as an individual basis and in consultation with a toxicologist. But generally, patients are giving just one dose, which is the standard 15 mg per kg. It is being considered in cases with hemodialysis, and we're collecting more cases, and there's more to come. But don't be surprised, I guess, if you start to hear about this. So again, just thinking about some cool new things that are happening in critically ill acetaminophen ingestions. Ask your tox consult about increasing your NAC and or giving fameprazole. All right, and so this is going to be the last case that we talk about today. And again, pivoting in a different direction, but is another good pull everywhere one. And again, I'm just going to flip and make sure it's active for us. All right, so case number 3, a 36-year-old male arrives in the resus bay following a reported fentanyl overdose. He receives naloxone en route, and on arrival, he's somnolent with small pupils and a respiratory rate of 6. You give additional naloxone and his respiratory rate improves. However, he's still somnolent and he has very large lower extremity wounds. You notice that these are the vital signs. What drug might be responsible? So a little bit of movement in the poll. All right. I think everyone who answered is going to answer. So if you picked xylazine in this case, you are correct. So the opioid epidemic has been actually hitting the headlines of our local newspaper quite a bit in the last week and a half. This was a headline, I think, just within the last few days that described the rate of fentanyl overdoses and overdose deaths in New York City. And it was a pretty revealing article. This data brief was actually just published this past month by the New York City Department of Health. And it shows sort of the neighborhoods with opioid-involved overdose deaths in 2021. And our backyard of East Harlem right here is within the top 5, with some of the other ones being up in the Bronx and Hunts Point. But you can see sort of up here and very close to sort of where we are and where we work, that there are neighborhoods where the overdose deaths are really taking over these local areas. And then this headline also recently appeared within the last, I think, also 2 weeks in the New York Times, talking about something called trank dope. Trank dope is something that is sort of near to my heart. I trained in Philadelphia. I was learning and sort of starting to see trank dope before I left. I moved to Oregon. And so it's sort of been known that this is going to be an evolving problem and has become really a tremendous, devastating problem in the Philadelphia area and is certainly heading north towards us to New York City. So what is trank dope? Trank is better known as xylazine. And xylazine is a central alpha-2 agonist that is not actually approved for use in humans. It's typically used by vets in combination with ketamine or opioids for large animal anesthesia or pain control. And like I said, it's known by the street name trank or trank dope. It was first actually described in Puerto Rico as being an adulterant in the drug supplies in Puerto Rico, known as the term anestia de caballo. And that was almost now 10 or 12 years ago, but now it's becoming increasingly detected both in overdoses and in drug products and drug equipment and in overdose deaths. Most of the case reports of large xylazine-only overdoses describe primarily neurologic and cardiac effects, things like CNS depression, bradycardia, hypotension, and cardiac arrest. But we're still learning a lot about sort of the clinical manifestations of xylazine when it is an adulterant in other drug supplies. So just to go over a little bit of terminology, because I think it's helpful. So cutting agents sort of fall into 3 categories. The first are your adulterants. So adulterants are pharmacologically active substances. They're intentionally added to enhance or mimic the effects of a drug or to protect against the deleterious effects of a drug. Diluents are sort of your inert substances that are added to just increase bulk. And then contaminants are unintentional byproducts that are present due to impure manufacturing or drug storage. There have been some historically famous drug adulterants, particularly in the New York City area. So back in the 1930s, quinine was actually added to supplies of heroin in New York City because there was a large malaria outbreak among people who use IV drugs. And so they were adding quinine in hopes of preventing the malaria outbreak from spreading further. And it did cause some quinine toxicity. There was a very famous back in the 1990s outbreak sort of across Manhattan and the Bronx of scopolamine in adulterated heroin. And there were these index cases that sort of popped up throughout the city, and good communication with the poison center allowed people to start identifying them a little bit better and actually treating the scopolamine toxicity with physostigmine and having very good results for the patients. And then another one that sort of is still out there, but is levamisole, which has been an adulterant in the cocaine supply. Levamisole is an anti-helminth and immunomodulatory drug, and it's added to sort of lengthen the effects of cocaine, but it does have these side effects of agranulocytosis and then this vasculitis and purpuric rashes that patients can get on their nose, on their ears, sometimes on the extremities that's related to levamisole. And then sometimes your adulterant in one illicit drug ends up being a different illicit drug. And so this was a letter that was published by my colleague, Dr. Khatri, about a outbreak of cocaine that was contaminated with fentanyl in West Philadelphia. And over a period of 36 hours, the hospitals in West Philadelphia took care of 18 patients with severe fentanyl toxicity. And several of the patients ended up in the ICU. A few of the patients died. And the patients, when we were able to talk to them afterwards, all thought they had been and intentionally been using cocaine. And it was clear that the fentanyl had somehow gotten into the sort of cocaine supply that was being provided in West Philadelphia. So you might be wondering, why are suppliers adding something like xylazine to fentanyl? And obviously it's a difficult question to answer, but we do have a little bit of data about it. So this is a mixed method study that was done using some ethnographic data from field conversations with patients in Philadelphia. And they note that xylazine alters the high effects that are associated with opioids. Some quotes from people who use drugs and the harm reductionists say that xylazine adds legs to the high or extends the high that's associated with fentanyl. And so what a lot of people will describe is that fentanyl causes sort of these abrupt peaks and drops where you have this peak high and then a quick drop off, whereas heroin used to sort of create this high that was like a high and then sort of kind of extended and then was a much slower drop off. And so some people feel like the inclusion of xylazine sort of gives them a little bit more of that extension and less of this sort of peak drop effect that can make people feel pretty sick. And so we actually did a study here that was a multi-center prospective cohort study in combination with a group called Toxic, which is a collection of emergency departments across the United States. And we enrolled adult patients who had an opioid overdose and presented to one of 9 emergency departments between 2020 and 2021, so over about a year period. And we had collected serum from them and ran it to detect all current illicit opioids, synthetic opioids, xylazine, and other adulterants. And then the analytes were linked to patient clinical data from the medical record for that encounter. And what we found was that xylazine is, largely in the Northeast. These East Coast representation was sort of the New York, New Jersey, Pennsylvania area. The amount of total naloxone that patients need is actually not drastically different, about 2.83-ish milligrams in the non-xylazine patients compared to about 3.5 in the xylazine patients. And interestingly, their vital signs weren't super different. The inclusion of xylazine didn't cause patients to be super hypotensive or bradycardic. They were pretty similar across the groups. But when we looked at 2 independent sort of clinical outcomes, one was coma within 4 hours, and then the second one was cardiac arrest. It was really interesting that the patients who had xylazine detected actually had a lower odds ratio of both of these severe clinical outcomes compared to the patients who did not have xylazine detected. We still don't really know why that is. We don't know if it's related to the concentration difference that including xylazine as an adulterant sort of decreases the amount of total fentanyl that a patient would have, and that might cause them to have a fatal overdose. We don't know if it's related to the xylazine and sort of if it causes different like clinical effects that can be sort of stabilized and maintained when a patient comes into the emergency department who's sick. We're still doing a lot of further work, but it was a very interesting finding for us. And then the last thing I just want to talk about in our patients and sort of something that we are also actively working on in terms of caring for this community are the wounds that the patients have. So the wounds are related to xylazine directly. They're not necessarily because the patient is injecting and introducing bacteria in that area and causing a bacterial abscess. There's something about the xylazine that is causing these wounds, and we don't exactly know why. Patients will describe that they're developing these, devastating wounds in places that they're not injecting at all. And these wounds can be quite severe. They've been reported to require things like multiple skin grafts, amputations, severe wound care. And so I just want to sort of point this out to you guys that if you do see a patient with in the ICU who has these wounds, trying to get them connected to wound care, get them wound care while they're in the hospital. It's related to this adulterant and trying to continue this care for them so they don't end up in a place of requiring amputation is really going to help them in the long run. So just to summarize a little bit about xylazine, so adulterants, they're added intentionally to enhance or modify the effect of a drug, and xylazine is increasing in prevalence. Like I said, it's very prevalent in the Philadelphia area. It is coming to New York City. They may have less severe clinical outcomes. We don't know for sure, but they do have these very severe wounds and tissue injury, and it's something that we have to be mindful of and really provide them care. So in summary of all of my slides and the things I talked about in sort of tox trending topics today, will it dialyze? Consult X-Trip and always your toxicologist. It's not just NAC anymore for your massive acetaminophen ingestions. Consider things like higher concentration NAC and famotidine. And xylazine, like I said, it's this alpha blocker that's found in the synthetic opioid supply. It's associated with these severe wounds, and it will become increasingly prevalent in our area and in our patient population. And that's the end of my talk today. If anybody has any questions or things that they would like more information about, I'm happy to answer them. Again, thank you so much for having me. I love talking about toxicology, so this is really a great honor and a great fun opportunity for me.
Dr. Love, thank you so much. That was great. Your true inner nerd really shined with those biochemical pathways. I can't judge being a PhD in chemistry, but I did appreciate it. So I'd like to open the floor up to questions. Dr. Matthew is asking, has mentioned that he's seen higher than normal rates of cardiac arrest in young patients. Any preliminary thoughts from toxicology community about this? And thanks for the great talk.
Higher cardiac arrest in young patients with overdose or with opioids specifically, or?
Let me let Dr. Matthew, hold on.
Sure.
Wow. Okay, Dr. Matthew, you should be able to ask your question directly.
Thank you. Yeah, specifically with the overdose, a lot of times, it's cocaine positive or opiate positive, but it seems that the patients, again, the volume is higher than past years. So again, the question is, whether some of these drugs are laced with our other items, and how do we, go about combating this?
Yeah, it's a great question. And I think that the data that we're seeing with the increasing prevalence of fentanyl is really probably what is responsible for it. That because patients, when I talk to patients in the emergency department, they don't always know a lot about fentanyl, and sort of we're trying to encourage people, particularly to test their drugs. We hand out test strips, or I hand out test strips very often from the emergency departments, that patients can kind of know if they're what they think is heroin or what they think is their, pressed Oxy 30 has fentanyl in it or not. And I think it's the contamination or the introduction prevalence of fentanyl that's causing just they use what they think that they normally use, and the fentanyl causes the increased toxicity, and they overshoot, and then they end up overdosing, and there's this subsequent fatality. I think also sort of the things like the on-point system of trying to create these safe injection sites where people can use in a supervised setting such that, they can be resuscitated. But it was a big problem in Philadelphia. There used to be a very large encampment below one of our train systems where people were using, but they were using in a community, and they were using sort of supervised, and there was a lot of naloxone available. And so people would sort of rescue each other, and then they tore that whole encampment down, and more people were using in isolation. And that, I think, also creates a very unsafe environment for people who are using and don't know how much is in there, and also think they're using something and it's adulterated with something else. And so I don't know sort of the changing landscape of anything in terms of, housing availability and whatnot in the city has also sort of affected this, that more people are using sort of individually or just with another person. And that also is sort of subsequently causing a higher overdose death rate.
Thank you. Dr. Love, my question is, how we used a lot of Mars where I trained during fellowship. It was we had a lot of fun with it. We used it mostly in like the like acute liver failures, like as a bridge. There was a couple of patients that we had who for whatever reason wound up, like we had one that was going for a liver transplant, the liver cracked in half before they put it in, and they wound up coming out of the OR without a liver and getting put on Mars for 2 days until they could get a second liver to retransplant. And so what are your thoughts on, I know there's not great data on it, but what are your thoughts on the future for Mars and that stuff? I'm
I
interested.
mean, I think it's really cool. We always talk about it as like this really cool concept and thing. The other one that's sort of also sort of we talk about in concept is the idea of like a temporary transplant, right? Where you do a partial transplant and don't immunosuppress them and then like remove it, right? Because they're able to sort of clear the toxicity with the partial transplant. I think that because it's case reportable, like, and the case in talks, we do a lot based on case reports, but the case reports here are even so small that we don't like generally have the capacity to recommend it. But we've certainly talked about it, or if somebody brings it up, I think Alaska has brought it up with us before. I think maybe they have some connection to it. And so we've said, hey, if you think that this is a potential option for you as a bridge, and we're throwing a last ditch effort to bridge somebody to transplant, we can give it a try. It's just that it's usually so inaccessible to us.
Great, thank you. Norma, what do you want to write your question in the Q&A, or what question do you have, Norma?
Yeah, my chat is being disabled. I don't know why, but anyway, one of the things I have, how much effort is going into prevention, namely educating the drug-using populace about these dangers, because clearly maybe their urgency for that need for the high exceeds their willingness to listen. But I remember eons ago when one of our cardiologists literally went on 125th Street with borrowed syringes to stop the tetanus epidemic in New York from the heroin injectors, because we were seeing so many of these cases, and of course they frequently died. And he literally set up in a corner, giving out clean, sterile syringes and collecting used ones to prevent that scourge. And actually it worked, at least in Harlem. So I'm wondering if there's any effort to make education a bigger part of prevention of this devastating disorder, because even when we do all these things, people are still dying.
Yeah. You're totally right. And it is a multimodal approach that we have to use to really try and stop this in the best way possible. I know, organizations like On Point, where they have set up these safe sites, are, trying to hand out things like clean syringes and test strips and naloxone, and we hand out a good amount of naloxone from the emergency department. We have our health educators who go and teach patients how to use naloxone, and we give it out for free. There's test strips contained within our naloxone kits so that people can test the drugs that they are using in an effort to try and prevent these fatal overdoses. Because really, when you talk to a lot of people who use drugs, it's not, they're not necessarily honestly trying to get high. For them, it's a lot more about preventing withdrawal, is that they just don't want to withdraw because they feel so miserable, and because the prevalence of fentanyl right now is causing sort of this awful prolonged withdrawal that we think is related to its fat solubility. And so patients will try to stop using I've had patients tell me they've tried to stop using for up to 5 days to try and get off onto something like methadone or buprenorphine or whatnot, and they're still having precipitated withdrawal 5 days later when they try to go on these other medications. So there's a lot of effort, sort of the REACH clinic and the Relay team, and the few addiction medicine internists who are within the Sinai family, who are wonderful and really try and work with patients. We are trying, but there's always more that we can do in terms of trying to limit this. I try and, whenever I actually prescribe an opioid to anybody from the ER, which is not actually that often, but when I did do this more frequently, I actually would always co-prescribe naloxone to them so that they had naloxone in their house. I know also that things like the I believe it's all bars in New York City now are required to have naloxone at the bar in case of an overdose that occurs in that setting. There's some efforts that are being tried from colleagues of mine that are trying to make naloxone available in, wherever an AED is stored, such that naloxone is more available in the community and accessible to people in the community. But yeah, people are trying a lot of creative ways to help prevent things from getting worse.
Jen, thank you so much. Is there anyone else with any other questions? If not, we can let Dr. Love go. And thank you so much for that very interesting talk. I really appreciate your time.
Thank you all. Have a great day.